Hello and welcome to the World Shared Practice Forum. My name is Tracy Walbrink and I'm one of the Pediatric Intensivists at Boston Children's Hospital. We have with us today Dr. Kamat. Dr. Kamat is Associate Professor of Pediatrics at Emory University School of Medicine, and he's also the Director of the Children's Sedation Services at Egleston Hospital in Atlanta, Georgia. Well, welcome, Dr. Kamat. We're excited because you've made outpatient pediatric sedation really your academic focus, and it's an area that a lot of pediatric intensivists are participating in and directing around the world. And can you tell us a little bit about how is it that the pediatric intensivist has gotten involved in outpatient pediatric sedation?
First of all, thank you, Tracy, for having me at the World Shared Forum. I don't have any disclosures or conflicts of interest. I think to answer your question, I think there's an increasing demand for procedures to be done outside the operating room, and there's a shortage of pediatric anesthesiologists. So the question becomes, what about other pediatric subspecialties kind of filling that gap? And I think pediatric intensivists are the perfect physicians to kind of play that role. We manage airways and hemodynamics of very sick children in the PICU, and it is kind of very natural for us to kind of attend to patients outside the ICU who may need airway management while they're undergoing sedation. In a survey that we did, we surveyed all members of the Pediatric Research Consortium, which is the research arm of the Society for Pediatric Sedation. We found that 78% of all sedations were done by the pediatric intensivists. Pediatric intensivists see very sick children. Many times we see a lot of death and dying, and outpatient procedural sedation for them is a good break from the high acuity and high complexity environment. So it's a good thing to go outside and talk to a normal patient, if I can say that, who you are going to sedate and then wake up and send home. That is one. I think a lot of senior ICU doctors who have done critical care for 25, 28 years, who for whatever reason want to not work in the ICU anymore, I think sedation is a perfect place for them to transition as they're going towards retirement. And so they can work in sedation, which they can use the ICU skills, but it is not as complex or high acuity. What is the difference between sedation we do in the PICU versus the sedation in an outpatient setting? So I think in the PICU, we know our team very well. We have the same nurses, RTs on a daily basis. And so there's a lot of support within the PICU. The other thing that happens in the PICU is we take airway instrumentation for granted. I mean, we can intubate any patient anytime. There's ventilators available. There's a lot of different sort of monitoring that's readily available. And more importantly, we have easy access to our patients. Now, in the outpatient setting, what happens is your airway rescue skills become more important because instrumentation of the airway is not your goal. And in fact, that some may consider that as a failure if you try to intubate every kid in the outpatient arena while you're doing a sedated procedure. The other limitation of outpatient sedation is you may not have a plethora of providers. You may have limited resources, and most of the time you have a nurse or a tech who helps you with the procedure. There's also limited monitoring and the access to the patient, because if the patient is put in this MRI magnet area, you may have limited access to the patient. What's the data that is supporting what how ICU doctors do outpatient sedation? So I published a paper in 2015 in Pediatric Critical Care Medicine Journal, where I looked at about 91,000 sedation encounters. And basically the primary outcome was to look at adverse events and something called as serious adverse events, which I'll explain to you in a second, and overall procedure success. A secondary outcome was to look at adverse event by location of sedation and look at the risk factors for an adverse event. So what we basically found out is that most of the sedations that were done by the pediatric intensivists were done for radiology procedures, basically radiology imaging. The second, about 25% of what they did in outpatient sedation area was for hematology oncology procedures, which is basically LPs and bone marrows. And they sedated a variety of patients, but most of them were under ASA status less than 3. Because I think most people would agree that as we go to an ASA status of 4, that goes into kind of a general anesthesia, anesthesiologist area. When we looked at the overall adverse event rate, and when I say overall adverse events, I'm looking at things like hypoxia, desaturation, coughing, secretions, was very low. For the 91,000 encounters, we had just about barely 5% of kids having adverse events. But I think most providers will be interested in what we call as serious adverse events. And serious adverse events are basically events that can cause irreversible neurologic damage, and that includes cardiac arrest, aspiration, death, like laryngospasm. Some people may even put airway obstruction in this camp, because if you don't take care of airway obstruction early, you can go down the spiral of cardiac arrest. And the rate of serious adverse events was about 2.2% for this 91,000 encounters. The good news is no patient died, and only one kid had cardiac arrest, but was discharged home neurologically intact. Mm-hmm. So what are the risk factors for an adverse event? So we did like a multivariate logistic regression and went back and looked at what are the, what puts a kid at risk for having higher complications. And from a location standpoint, we found out that kids who have procedures done in a dental suite, kids who had procedures done in a cardiac cath lab were at a higher odds to have complications, which makes sense because these kids going to the cath lab obviously have some cardiac problem, and so they are sick to begin with. The dental sedates, the approach to the airway is difficult because they're working in the mouth. The other thing we found out is the more drugs that are used, there was another reason to have an adverse event. So intensivists need to be careful. The usual scenario is you give midazolam, you give fentanyl, the kid doesn't get sedated, then someone else comes and uses some other drug. So the drugs keep on piling up, and you have an additive effect. So the more drugs you use, the your adverse event rate goes up. We also found out that painful procedures actually decreased the odds of having an adverse event, and that has been shown in the literature before, that painful procedure can kind of stimulate the patient to have to breathe, and so therefore have less complications.
We'd like to take a moment now to involve our viewers in the discussion by asking a question. In your response, please state your city and country location. The question is this: do you have an outpatient pediatric sedation program at your hospital? And if so, who is responsible for delivering the sedation?
The question becomes, what are the procedures intensivists can sedate for? And I like to tell providers that procedures can be diagnostic or therapeutic. We can then look at procedures as those that are non-painful, which we consider as non-invasive. And usually these are radiology procedures. They are a patient who's needing MRI or a CT scan or nuclear medicine scan. Or they can be very painful procedures at the other extreme, which we call as invasive procedures. And these are usually oncology procedures for bone marrow or renal biopsies. Those can be very painful. And in between, we have what we call as distressing procedures, which are minimally invasive procedures. They're not exactly painful, but they can cause the situation to be very distressful for the patient. And a good example of that is placement of a Foley catheter for the VCUG studies, or even an IV placement for kids can be very traumatic. Okay, so the other way, the learners ask me, what's the best way to select what drugs we use for sedation? And I always point them out to this slide, where on the y-axis I have the degree of pain, and on the x-axis I have the level of immobility required. And I tell them you basically need to follow the boxes in this graph. And if you go to the extreme right, you see that procedures that need the highest level of immobility, as well as the highest, the degree of pain is very high. That's a procedure that's going to need good pain control, as well as the patient to be kind of sleeping for that procedure. So a good example of that is a bone marrow biopsy. It's a very painful procedure, and you do not want the patient to move as they're doing the bone marrow biopsy. So that's a patient who's going to need analgesia as well as a good sedative for the procedure to complete successfully. The other thing I think ICU doctors need to be very careful about is sedation is a very slippery slope. There are different levels of sedation, and these levels are not defined by drugs, but they are really defined by the patient's response. So if you give a drug to a patient, but the patient can respond to verbal commands, we call that mild sedation. A classic example of it is a patient who got a little small dose of oral midazolam, and he may be a little groggy, but still is able to respond appropriately. On the other extent, we have general anesthesia, where the patient cannot be aroused, and very frequently you may need actually airway or even cardiac support for the patient. In between those two extremes, you have moderate sedation, which they previously used to call as conscious sedation, where the patient will respond to a light tactile stimulation. And then you have deep sedation, where the patient only responds to a painful stimulus. So a drug doesn't really define what level you can remain at. It's basically the patient can slip from mild sedation level to almost general anesthesia. So the point I'm trying to make here is A, monitoring is the key, and B, you need to be ready to kind of recognize and rescue any airway complication that can take place. Another classification that is very frequently used in the anesthesia world is actually the American Society of Anesthesiologists, what they call as ASA physical status classification. Usually level 1 is a healthy patient. Level 2 is a patient with some mild systemic disease. Level 3 would be a patient with severe systemic disease. And level 4 would be a patient who the disease is a constant threat to their life. And level 5 is a patient who's not expected to survive the next 24 hours with or without the surgery. So the first 3 levels, especially the first 2 levels, the patient is not at the highest risk in case he had to have anesthesia. So those are the 2 levels, and some that are very easily done in an outpatient arena. Intensivists are highly specialized, trained providers, and they can do even level 3, PS level 3 sedation.
So that was an excellent overview of outpatient pediatric sedation. I wonder if you could talk us through a little bit about how you got started to develop the outpatient pediatric sedation program at your hospital.
I think that's a very good question, because I think a lot of people have, like how to get started is their main, is the biggest question. Everyone has good ideas, but how do we get started? A lot of things are done by anesthesia, and suddenly intensivists want to jump and kind of do the same thing that anesthesia does. So I think what happened was prior to 2002, we didn't have a lot of newer drugs that could be used for sedation. We had drugs that were kind of drugs that like pentobarbital or chloral hydrate that were used for outpatient sedation, and radiologists kind of led a lot of this sedation at that time. There were a lot of nurses who were either cardiac ICU or PICU or ED nurses that kind of handled sedation at that point. As in 2001, more studies started coming out telling us about possibility of radiation risk with CT scans. And so a lot of referrals started going away from the CT scans to MRIs. And so what happens is when we do MRIs, patients need the procedures, the studies are longer, and patients usually need sedation. So there has to be some sort of an organized fashion in which the sedation is provided to these patients. So I think the hospital initially approached the anesthesiology physicians, and I think they were not quite able to meet the demands of outpatient procedural sedation. And then I think the next automatic group that was kind of came on the radar was a combination of ICU doctors and ED doctors, two pediatric subspecialties that are really skilled in managing airway and hemodynamics. And I think we stepped up to the challenge, and we kind of provided outpatient sedation at our hospital. So I think what we did very good is we complemented what anesthesia did. We didn't compete with them. We showed a lot of success in the procedures that we do. And so as we did very well in radiology, other services started seeing the benefit of outpatient procedural sedation, the ease of, easy to schedule, patients and parent satisfaction. They come in, they are discharged the same day. The other important things is the operating rooms are freed so that the operating rooms can be used for more complex procedures. So other services, for example, the nephrology service wanted us to do their renal biopsies. So we started doing renal biopsies. The hematology oncology physicians wanted us to start doing LPs and bone marrows in the outpatient clinic. And so it was kind of a win-win for everybody. And that is how we, as ICU docs and the ED docs, started the service at our hospital. We now have 3 full-time physicians who do sedation. We have 2 ICU docs who do sedation and 1 ER doc who does full-time sedation with us. We have a staff of other PRN docs whose primary job is either in the ER or the ICU. They also do sedation for us. And we have 1 anesthesiologist who also picks up some shifts in our sedation service. We also have an excellent team of well-trained nurses, and as well as a lot of techs who work in radiology or outside that are very skilled and exactly know what we do in outpatient sedation. The other thing that we have implemented at Children's that has been very successful is sedation at a freestanding imaging center. And I think we were the first to report our success, where these freestanding imaging centers are pretty far away from the main hospitals. They really don't have a code team, although they have well-trained nurses. They have a code card, and the sedation doc who is providing sedation there is very competent. We do not send any physician there till they have a good 3 to 6 months of training in the main hospitals. And when we looked at some data, we found out that of the almost 700 sedations that we did, and mostly they're ASA 1 or 2 kids, we had 99% procedure success, no serious event, no cardiac arrest, no death. The selection criteria for this outpatient freestanding imaging centers is slightly different. We do not do as sick kids as we would have done at the main hospital. We do kids who are mostly ASA 1 or 2. We do not do kids who have cardiac issues, kids who are very premature, and we usually try to do kids who are more than 6 months old. So what about, infants who are very small? I mean, who are like less than 6 weeks of age? Many times when they are referred to my sedation service, we will talk to the referring doc if he's a pediatrician or even a pediatric neurologist and say, how urgent is the study? Can the child wait for another couple months? Can he grow a little older? And most of the times the pediatricians or the referring doc will work with us and say, this is not urgent. This is just a screening study. You can wait for another 2-3 months. Our nurses do a very good job in trying to feed this kid and kind of bundling them and putting them to sleep so they can get most of the study done that way. They also use techniques called a papoose, that is a pneumatic blanket that the kid can be put into, and once it's inflated, the kid really just goes to sleep and stays still. Although none of these techniques have been shown to be superior to sedation as such. The other thing that we do is any kid who is less than 60 weeks post-conceptual age, we kind of usually observe them for at least 12 hours in the hospital. There's some reported, well reported in anesthesia literature that this small babies, especially if they're ex-preemies, can have apnea following general anesthesia. So we kind of follow the same rule. And I want to caution people who are watching this that infants less than 5 kilos present a higher airway risk in general for sedation. As a center, because we do so many kids, we looked at our experience with kids who are less than 6 months of age. And we found that we have done a lot of those kids. And in one report that we published in Pediatric Radiology, of the 304 infants that we looked who are under 6 months who received propofol for MRI, first of all, about almost 20% of them were less than 3 months of age. We found out the procedure success rate was close to 99%. There is a slightly increase in adverse events, almost about 12.8%, which is much higher than the 5% I quoted before. And the serious adverse event rate also was about slightly higher. It's about 4.3%, which was 2.2% for other general population. Again, no kid had cardiac arrest or no kid died. There was one kid who had laryngospasm, survived neurologically intact. I think the take-home message here is, yes, you can do kids who are under 6 months of age, but you need to be really skilled at recognizing and managing airway complications.
We'd like to take a moment now to involve our viewers in the discussion by asking a question. In your response, please state your city and country location. The question is this: do you have a formal screening process in your hospital for outpatient pediatric sedation? And if so, who does the screening?
I want to caution of people watching is that we are an elective service, meaning we will not do emergency sedation in an outpatient arena because the patient may not be appropriately fasting. We are also not a service where if the patient needs a breathing tube, we do not want to sedate them because they need a breathing tube for a reason. And we do sedate kids from the ICUs and in the inpatient area. We just bring them to the outpatient area and sedate them. And we do also do a lot of consults where if someone has a question whether a patient is a sedation candidate or not, we can go and kind of do the consult for the patient. I think, Tracy, the thing to remember is although we have a very large sedation service, as a group, we give every kid a chance to do the procedure without sedation. And most kids who are, more than 6 years of age, as long as the procedure is very short, they're not claustrophobic or have high anxiety levels, probably can do a lot of this non-painful, non-invasive procedures like an MRI. We try to involve parents in that process. We try to keep one parent in the MRI with the child. We use the services of child life specialists, and they use a lot of distraction techniques. They may be showing them a movie. We have goggles where they can watch movies through. They can listen to music. We use we have a therapy dog and his name is Ty, and he has helped us with a lot of short CT scans where patient doesn't even have to get an IV. So we try to not to sedate kids who do not need sedation. Okay, and so if the kid needs, it's a long scan. Kid needs to be, not moving for a long time. That's difficult for a small kid. So that is the time we may have to provide sedation to get the best images. And also when contrast is used, okay, whether it's in CT or an MRI, as soon as the contrast is injected, the kid gets a very funny feeling that they feel warm, get a metallic taste in their mouth, and they may want to move. So at that time, they may probably need some deeper level of sedation just to stay still during the process when the contrast is injected.
Well, that's interesting. You've described a lot of ways in which the environment that you're working in is quite different from the ICU in terms of equipment and personnel, and yet you still have a pretty excellent safety record. And I'm curious, what policies and procedures have you put in play within your sedation program to ensure the safest delivery of sedation for these patients?
First of all, the team composition. The physicians who can work in sedation are either drawn from the critical care group or the ED group or anesthesia, because all this physicians from these three areas are experts at airway management and recognizing and managing hemodynamic complications. We take physicians into sedation and watch them for about at least 10 sedations where they are proctored and supervised and by another experienced physician. And so they kind of learn all our procedures and policies and what we do for safety. The other thing that we do before every sedation is we run a checklist with the nurse and the physician in the room, and also the parents participating in this checklist, where we check airway equipment, suction, oxygen, not just at the wall, but make sure that it's actually functional and working, and the mask is the appropriate size. We double check the drug that we use, which is usually propofol. We check the bolus dose, we check the infusion dose, and we check the kid's weight. It's done multiple times to ensure a fail-safe approach to the sedation. In the kids that are slightly higher risk, we will discuss with the team up front. We will also let the parents know during the consent process that, little Johnny here is a little higher risk because he's having cough and obstructive sleep apnea symptoms. But the good thing is we're using drugs that are very short acting. So if we get in trouble, we can very quickly shut off the drug and rescue the airway. The other thing that is unique to our program is we have developed a rescue kit. And that rescue kit has drugs like flumazenil, Narcan, atropine, and succinylcholine. And these are, if we use fentanyl and if kid stops breathing, I can quickly use Narcan and reverse that. And same thing, if I use a benzodiazepine, I can use flumazenil and reverse that. If I get into the dreaded complication of laryngospasm, I can quickly reverse that. First, I would give a higher dose of propofol and see if that kind of relaxes the spasm. But if that doesn't work, I'm going to give succinylcholine, which usually causes a little bradycardia, so I will give a little atropine behind that. So this reversal kit will go with every patient in whichever area the patient is sedated with. We do a lot of training of our nurses. Brenda is our educator who makes sure that nurses go through all the latest competencies that they need to go through, because there's a lot of regulation when you do outpatient sedation. We encourage all our physicians to attend the sedation conference. They have a simulation course where they kind of teach sedation simulation, so they can go to that course and kind of develop their skills. So we kind of, and we look at all our failed sedates every week, and we have to present a report to the Anesthesia Quality Council to make sure that, we're not failing in one particular area. And then, as I talked about, the preparation for sedation, we use a mnemonic called SOAP-ME, which is a very common anesthesia mnemonic, and I probably describe all the components of it already. And then we also use a thing called sample assessment, which is a very common thing used in secondary assessment of the advanced life support courses. And so when I say sample, I quickly look at what the signs and symptoms of the kid has. I sometimes even put snoring in that. I look at the kids, I see what the allergies kid has, the medications the kid is taking, especially focusing on medications that may interact with my medications that I'm going to give. And for example, if a kid is coming to me from hemonc, he may be on a continuous morphine PCA. And if I give a huge dose of propofol on top of that, that may have complications. I also look at the kid's past medical history. That's a very important thing to do, because if in his previous sedation, the kid had a bad interaction with a certain drug, you may want to avoid that drug during this sedation. We also sometimes go back and look at what the course of the kid was if he had to go to the operating room. Was he a easy bag mask? Was his airway easy? So those are very important things to know before you put a kid under sedation. And of course, we want to know when the kid ate last. and any events that led to this injury or illness. So we also have very robust pre-sedation screening guidelines. And we go about screening kids by organ system. So if a kid is, has tracheomalacia, laryngomalacia, where I know he's going to need he or she is going to need positive pressure once I give deep sedation, that may not be a kid for me to sedate. That may be a kid that is best done by the anesthesiologist. And so we have, by consensus, built a lot of conditions that where we would not go and sedate. For example, a patient who has a mediastinal mass. Those kids are dangerous even for the anesthesiologist. So they are definitely not kids for my candidates for sedation. So we will exclude a lot of those kids who are very high risk and who really need the services of an anesthesiologist. We consult with our anesthesiology colleagues very frequently. We discuss with them high risk kids, and many times if they say this kid is okay for us, we will take him into sedation, or they may take him to anesthesia and try to sedate him the way we sedate, and if they don't get in trouble, they would send him to us for his or her next sedation. We also talk to a lot of other subspecialists. If it's a cardiac kid, we may talk to a cardiologist. If it's a kid who has pulmonary problems, we will talk to the pulmonologist. So we have a really a very good team approach to this, because I think I go by the premise that asking for help is not a sign of weakness, and I really want to make sure that the kid is served well, whether he needs sedation or he needs the anesthesiologist. So we before we sedate the patient, we also go about doing a very good airway exam. And this may not be possible in kids who are very small, because most of these airway exams are for kids who are older than 12 years of age. I sometimes look at what we call as 3-3-2 rule, where I can, by the first three of the 3-3-2 rule is where I tell the kid to put his 3 fingers in his mouth, and if he can, that basically tells me there is a wide mouth opening. The other 3-3-3, the second 3 of this 3-3-3-2 rule basically looks at the submental area. That basically tells me that there is enough space for the tongue to be displaced in case the kid needs an intubation. And the last 2 of the 3-3-2 rule basically assesses the position of the glottis in relation to the base of the tongue, kind of indirectly tells me how anterior the airway could be. So that is, again, this thing may not be able to do in a kid who is 2 months old, but kids who are older than 12, this is a good exam to do. The other thing that I do is I look at their Mallampati classification. Again, an exam that may not be doable in a very small child, and you want to tell them to open the mouth very wide and put the tongue out, and you basically want to look at the exposure of the tonsillar pillars and the uvula, which would be like a Mallampati 1, and then you have Mallampati 4, where you just basically see the middle part of the tongue. Okay, those patients are generally not considered to be sedation candidates, especially if they have other comorbidities. We would actually give them to the anesthesiologist. And then there are certain kids that we would not sedate. Kids who are potentially have a lot of syndromes with airway difficulty. Okay, a good example of that is kids who have retrognathia, Pierre-Robin syndrome. Kids who have mid-face hypoplasia, Cruzon syndrome. The other thing I watch for sometimes is kids who have a lot of hemangiomas on their face. We want to make sure that similar lesions are not present in the airway. So in case I sedate, I don't lose the airway. And those are the kids we have talked to the ENT doctors, and they have even scoped the kids before we sedate the kid for a long MRI procedure, because that I want to make sure that the airway is patent and open before I sedate the kid. We also do extensive monitoring of the patient. We get baseline vital signs, which includes heart rate, respiratory rate, blood pressure, baseline pulse, oxygen saturation on a pulse oximetry. Once the kid is sedated, we usually use end-tidal and measure an end-tidal. and see and make sure that we have a good waveform. The kid is exchanging CO2 well, and we rely on a lot of capnography waveform to tell us, make sure the kid is not apneic, or the kid is not having what we call as hypopneic hypoventilation, where the tidal volume is low, but the kid has a good rate, or the kid can have what we call as bradypneic hypoventilation, where the kid's tidal volume is normal, but the rate is low. Okay, so I'm not exactly watching a number in the end tidal, but I'm also watching the waveform very closely.
I wanted to go back a little bit to your pre-screening and evaluation process. You mentioned a lot about some of the kind of more obvious diseases that would be, important not to sedate in an outpatient setting, such as retrognathia, some complex congenital heart disease. But I'm curious what you do with some of the more common and maybe less obvious patients that are at a little bit higher risk, such as those patients with obesity or behavioral problems like autism. What's your generalized approach to thinking about those patients? And, do you have a framework that allows you to think about how or when you might sedate these kinds of patients?
Tracy, that is a very good question. And I think what limits us on what we do in sedation is there's not a lot of randomized controlled trials out there. But the large databases like Pediatric Sedation Research Consortium, from the Society of Pediatric Sedation, have really helped us to kind of derive some associations when we sedate kids with different conditions like obesity or autism. They had more desaturations. They were hypoxic. Some of them had upper airway obstruction, needed bag mask, CPAP, and even airway instrumentation. Like when I mean airway instrumentation, is in an oral airway or an NP tube. So they can be sedated, but I think the people, the sedation providers, need to be ready and anticipate that such complications can happen in these obese kids. The obese kids that I'm worried about are the ones that really have other comorbidities with them. If the obese child has problems with his heart, has obstructive sleep apnea, has a recent URI that has very green mucousy phlegm being produced, that is a kid who is going to give you a lot of additive risk. And I would kind of caution sedation providers as to, hey, is this study really urgent, or can the patient wait for a couple more weeks before this inflammation has subsided? The children who have autism spectrum disorders are presenting their own kind of set of problems. Okay, they have a lot of behavioral issues, communication and sensory issues. They don't like unfamiliar environment, which you can imagine coming to the hospital is one. And the areas like MRIs are actually zoned off. So there's only certain area you can, the patients can have to wait in. They cannot kind of freely roam around. And the kids with autism spectrum disorders do not kind of do well with that. And I think there's some evidence that when they're subjected to traumatic stress like that, it can actually make them have regressive behaviors. So we as a center have a lot of experience in sedating children with autism spectrum disorders. We involve the child life specialist up front, who will actually call the parent a few days before and kind of talk to the parents and say, what does Johnny like? Okay, or what does he dislike? The answer could be he doesn't like bright lights. Okay, he doesn't like noises or something like that. So we kind of try to work with the family, and as the child comes in, kind of prepare those conditions. We try to keep the registration process very short. We may make him the first case in the morning so that he's not stimulated by other people around. And once the child comes in, the other big problem is placing an IV. And so what we have to do is, either in one study that I did, where I looked at kids coming with autism spectrum disorders and I compared them to kids who did not have an autism spectrum disorder, I found out that 10 to 12% of the time we need extra personnel to help with getting the patient ready. And it's usually the placement of the IV, which is very traumatic for this cohort of patients. And so once the IV is placed in, the drugs are the same drugs we would use for any other patient. And my study also showed that there was no higher incidence of adverse events when we compared kids with autism spectrum disorders to kids without autism spectrum disorders. Yes, we can sedate them. We just need to prepare well. We need to really use our child life services. We need to look at what are called as autism coping plans, and we can sedate these kids. The other big patient risk factor is upper respiratory tract infection, okay, and it's an independent risk for airway adverse events and needing more interventions. During the winter months, this is unavoidable. Like every second kid that comes in will have some sort of upper respiratory tract infection. And I think, as long as it's not, as long as the kid doesn't have lower respiratory tract infection along with that upper respiratory tract infection, kid is not febrile, is not having greenish mucousy phlegm, I think the kid can be sedated. And especially kids who come to the hematology oncology clinic, they require their bone marrow and LP because they are on a cycle of chemotherapy, and it's really not avoidable.
That's great. And you mentioned a little bit earlier about some of the earlier medications that were often used for sedation and how now that we're using different types of medications. And I'm curious if you could talk us through a little bit about what are the current kind of go-to medications that you're using in your sedation program. And are there any new drugs that are emerging that you're excited about that you think are going to help revolutionize the field of outpatient pediatric sedation?
Yeah, so previously, we when we first started, we used to use a lot of chloral hydrate, and so since 2012, chloral hydrate is not freely available anymore. So that drug has fallen out of favor. We also used to use a lot of pentobarbital, which is not used as much because I think what sedation providers are looking for are drugs that work really fast, are reliable, and don't have a lingering effect. What I mean by that is that once the sedation procedure is done, the kid can be woken up and can go home. Okay, that's what I think everybody is looking for. So now we have drugs like propofol, which is works really fast, has a very short action, meaning if I get in trouble, I can kind of stop the drug and rescue the kid. We also have drugs like ketamine, which are much more friendlier to the airway. They maintain airway reflexes, so that can be used for procedures that are painful. I like to use fentanyl a lot for my procedures as an analgesic because I have a reversal agent, which is Narcan. So in case I get in trouble with fentanyl, I can use Narcan. We also have a drug called dexmedetomidine that is being used a lot in sedation nowadays. One of the things is there's a lot of discussion happening about pediatric neurotoxicity, especially with the preclinical data showing that pediatric neurotoxicity can happen, but it's not been quite proven in infants and children yet. But and dexmedetomidine was one of the few drugs that is not shown to cause neurotoxicity as such. So it's a good drug to use to decrease the use of other drugs in outpatient sedation. I think what we are going to see in the future is a lot of use of intranasal medications. And what that does is intranasal medications, it avoids an IV. It is something that is good for quick short scans or short MRIs. And again, Dex is becoming one of the favorite drug to be used intranasally with a lot of sedation providers because they can do this, spray the drug in the nose, and get the procedure completed without needing an IV.
We have one last question for our audience. What are the common drugs that you are using at your hospital for outpatient pediatric sedation? In your response, please list your city and country. What else do you see as sort of coming down as the future of pediatric sedation in addition to, or different than medications. Is there anything else that you're excited about?
The other thing is that there's a lot of change in imaging modalities. I think we have seen that there are faster CT scanners now that kind of can scan the whole body in like 0.5 seconds, or can scan the brain of a child in 0.03 seconds. So what that does is that means that a patient can probably just lay down on the scanner with his mom at the side, or a child life specialist, without really needing sedation. So that kind of avoids sedation for them. The other thing to think about is MRI procedures are very long. MRI procedures, you don't really have good access to the patient once you put the patient in MRI. And so I think the practitioners can really think about, is this something where the kid who is slated to get an MRI, can he really just get a CT scan? The other good thing about this newer, faster CT scanners is their radiation risk is very low. And so, the previous concern used to be, hey, CT equals radiation risk, therefore let's do MRI. Maybe now we need to shift the paradigm and think about, can this kid have a quick CT scan and kind of avoid all the complications that could come with a prolonged MRI scan. And I like I pointed out earlier, there's a lot of things that we're going to hear about pediatric neurotoxicity. And I think as pediatric sedation providers, we need to be careful about and kind of be watchful about what exactly is coming out more from a lot of data comes out from an organization called Smart Thoughts, which is doing really good work in the arena of pediatric neurotoxicity. So I think we need to be careful about what procedures we are doing, how long these procedures are, talking about the risk, amongst ourselves and amongst the referring doctors and the parents. So I think we're going to hear more about that.
Well, I wanted to thank you for sharing your expertise today in the field of outpatient pediatric sedation. Not all of us are working in the outpatient arena, and it's really exciting to hear kind of what inroads and sort of advances have been made out in the field, and how really this can be done in such a safe mechanism. So thank you for your time and for being here to share your thoughts and expertise with our audience.
Yeah. Thank you, Tracy, and I want to thank the OPENPediatrics for having me here today to talk about outpatient sedation. If folks want to learn more about outpatient sedation, they can look at our website, which is pedsedation.org. The Society for Pediatric Sedation also has a conference every year, and we have a very good sedation simulation course just before the conference. The next conference is going to be in 2019 in May in Denver, and so folks can come and learn more about pediatric sedation at that conference. Thank you.
Wonderful. That's a great resource. Thank you.